Thank you, Nikki. On behalf of the Chronic Liver Disease Foundation and Ecosens North America, I'd like to thank everyone for joining our webinar entitled Fatty Liver Disease in Adolescent and Pediatric Patients. Today's presentation includes information on the uses of the FibroScan device from the published literature. Neither the Chronic Liver Disease Foundation or Ecosens intends to make any specific claims found in this presentation. The FibroScan device is FDA cleared as an aid to the diagnosis and monitoring of patients with chronic liver disease and is not intended for the treatment of any specific liver disease or condition. Now I would like to introduce Dr. Miriam Voss, the director of the Pediatric Fatty Liver Program at Emory Children's Healthcare in Atlanta. Dr. Voss completed her Pediatric GI and Nutrition Fellowship at the University of Louisville, followed by an Advanced Liver Disease Fellowship in Liver Transplant at Northwestern University in Chicago. She is a nationally recognized leader in pediatric fatty liver disease. Dr. Voss.
Thank you. It's really my pleasure, and I'd like to thank the Chronic Liver Disease Foundation and Ecosens for the invitation to do this educational webinar today. Let's get started here. So I'm just sorry, there's my disclosures. I work with a number of companies, as you can see listed here. So I think that, it's well known that obesity and diabetes are not just a problem in the United States or this continent, that this has spread to be a worldwide problem. And the growing information shows that pediatric non-alcoholic fatty liver disease is also a problem across the world. And the data here is the prevalence rate in the different regions across the world in children. So you can see in North America, 6.5%, Europe, 5.7%, Asia, 5.9%, the Australia region, 6.8%. So these are numbers that I find surprising, given that we were, just starting to worry about obesity in some of these areas, and now they already have such high prevalences of pediatric NAFLD. If you look at it in a slightly different perspective, this is prevalence within obese adolescents. So the prevalence of obese adolescents varies in the regions, but once you have an obese adolescent, what's the risk of having NAFLD? Well, again, shockingly high. So in the US, 24%, Mexico, 42%, some of the European countries, 28, 53, across over in Asia, 77%, 24% in Japan. So this is truly a worldwide epidemic in children. One of the questions I often get asked is are we just identifying NAFLD more, or is it increasing in the population? So we did this study a couple of years ago and looked at nationally representative data in the United States, and we used ALT plus overweight status as a surrogate marker of fatty liver disease. We looked at data in the that's from the late 80s to early 90s, and then compared that across several other data points, and then the last one was the 2007 to 2010 data set, and this is all from NHANES, which is the nationally representative data. So you can see, looking at the lines here, this top line is using an ALT greater than 25 for boys and greater than 22 for girls. And you can see that back in the late 80s, we were around 4%, and now it's just over 11 or just under 11%. So clearly a significant increase. So the spectrum of NAFLD in children is very similar to the what's reported for adults. So children can have simple steatosis with just micromaculovesicular fat. They can have NASH, non-alcoholic steatohepatitis, abbreviated NASH, which is a combination of inflammation, steatosis, and in adults, hepatocyte ballooning. But as I show you in the next slide, children less often have ballooning seen despite significant amounts of inflammation. Children can also present with significant fibrosis, although cirrhosis is much less common in childhood. We'll see earlier stages of fibrosis, stage 1 and 2. So I mentioned that there's some differences between the adult pathology results and children in fatty liver disease, and a couple of these are listed here. So the proportion with NASH in adults, it's really the minority. But in children, by the time a child undergoes a liver biopsy, that group of children is more likely to have NASH than not. And part of that's just selection, because we tend to biopsy those with higher liver numbers, AST and ALT. But part of it also appears to be that children have more severe disease. And that makes sense to me, because if you're getting a disease when you're a child rather than not acquiring it till you're in your 40s, 50s, or 60s, then by definition, you have a more severe form of the disease that had an earlier onset. On the right-hand side of the slide here, you can see a direct comparison between adult histopathology and pediatric histopathology that was described in a recent review published in Gastro. So here they listed that adults typically have zone 3 steatosis, ballooning, as we mentioned, lobular-based inflammation patterns, and then pericellular fibrosis. This is compared to what's described as the pediatric pattern, which would be the zone 1 fibrosis or periportal, and mainly periportal inflammation and fibrosis, and rarely ballooning. So kids will have this pattern, especially in the earlier ages, so 8 to 12, maybe 14-year-olds. But by the time they get into their late teenage years, and some kids just have the adult pattern. And so we see a pediatric pattern, but children can also commonly have the adult, quote, adult pattern. So why is, what happens with NAFLD? Well, it's very clear from the adult literature that NAFLD and NASH are associated with obesity, with an expanded and inflamed visceral fat mass, that they greatly increase the risk of cardiovascular disease. There's a significant risk of progression to cirrhosis over the decades, and then strong associations with type 2 diabetes. So many adults with NASH have type 2 diabetes, and many go on to develop type 2 diabetes after a diagnosis of fatty liver. So what's causing NAFLD? What's causing all of this? And we're getting more and more information about genetics, but it's interesting because it's clearly not just genetic. I mean, one, we can see that because the rate of increase is much too quick for a pure genetic disease. There must be an environmental insult. But also a number of studies are starting to give us good data on this. So this was a really interesting study that came out in Nature Genetics. They looked at a number of different genes that are associated with NAFLD, shown here on the right-hand side. And this is showing the PNPLA3 data. So they looked at folks who had either did not have the variant, were heterozygous for the variant, or the dark blue dot, they were homozygous, so they had both two alleles affected. And here they grouped folks by their BMI. So here's a normal or low BMI, here's overweight, 25 to 30, and then 30 to 35, and then this was greater than 35. So if their BMI was elevated and they were homozygous for PNPLA3, then they had elevated hepatic fat. And that was true, there was a trend here, but that was true at the obese and then also in the very obese. But even if they were very obese but did not have the gene, then you can see here that they did not have increased hepatic fat as shown on the left. So this is very interesting because it shows that not only do you have to have the gene, but you also have to have a second effect of being overweight. And when I read this study, the next question that came to my mind is, okay, well, what's driving the obesity then? And I've been very interested in nutrition as a driver of fatty liver, and so I'm going to tell you more about that later in this talk. But clearly, you have to have increased calories, and maybe it's certain foods that drive that. Here's another study that's fairly recent, looking at this longitudinal question about fatty liver. So in this project, we looked at data from the cardiac cohort. So here's this large cohort followed, initially set up for cardiovascular questions, but it has a wealth of information. So here are participants who are age 25, and then they were followed longitudinally up to age 50. And over these 25 years, some patients increased weight, some were more stable. And so the authors grouped them, the participants, by their type of weight gain. So they either had a stable BMI, a moderate increase in BMI, a high increase in BMI, or an extreme increase. And this is from their baseline BMI. So over here on the right-hand side, we can see, this bar graph here shows shows the prevalence of NAFLD divided by which category they were at baseline and then how much they increased. So look here, here's folks who were stable. So even if their BMI was pretty high, so they had class 2 or 3 obesity at baseline, their prevalence of NAFLD was low. And then if you look, let's go moderate increase, high increase. So if in the group that had a high increase in BMI, if they had a normal weight, they were still relatively low prevalent. But look at the prevalences here, 23%, 35, 42, 50%. So what this is telling us is that it mattered less what their baseline status was, whether they were overweight, obese, or not. It matters more whether they're gaining weight over the decades. And so here I put across here that basically weight gain is hypercaloric state, so too many calories. And so it's the too many calories plus genetic susceptibility and time that's resulting in the onset of NAFLD. So one other kind of interesting, relatively new factor that plays into what we know about the longitudinal nature of NAFLD is that steatosis is present at birth. So it's not that kids are fine and then they just pop up with NAFLD at age 10 or 12. There's several studies now demonstrating that infants who are born to obese mothers, particularly insulin-resistant obese mothers, have hepatic fat present already at birth. And what we really don't know is the role of these postnatal events. And this figure comes from a review that was discussing, the potential for all these other factors to affect the progression from fat alone to NASH to fibrosis. So putting this together on a timeline, so we don't have this kind of longitudinal data. And so what I'm doing is superimposing cross-sectional knowledge onto a figure here of the timeline of the life of a child. And so we know that insulin resistance in mothers is important, and there are ongoing studies looking at the role of diet in the in utero time period to affect children. Infants are born with fat. We actually don't know anything about the liver in this 2 to 8 age group because it's rare that a liver biopsy would be done. MRIs are not possible without sedation in this age group. So this is a difficult time to know what's going on in the liver. But we know that children who are age 5 who are overweight are likely to have insulin resistance and have high triglycerides. By the time they reach age 8, 9, 10, they're often presenting with NAFLD and NASH, as I mentioned. And then type 2 diabetes is the next step in this timeline. And in fact, the risk of a child who has NASH to develop type 2 diabetes during adolescence is about 3 to 4% per year. So my liver clinic has become a place where children, unfortunately, I am frequently diagnosing type 2 diabetes. And back when I trained 15 years ago, that would just be unheard of, that we would be identifying new onset type 2 diabetes in a liver clinic. That would be, happening at endocrine. So then, as we talked about, the later stages seen in adulthood would be cardiovascular disease, cirrhosis, hepatocellular carcinoma, and then going on to transplant. So our current understanding of the natural history of pediatric NAFLD is limited because we have very little long-term data. We have these cross-sectional looks that we can kind of put together, but no trajectory yet. Few children have repeat liver biopsies, so we have 2-year data on the difference in histology based on some clinical trials that had liver biopsies 2 years apart, but we don't have longer-term information about, say, the progression of fibrosis or other important questions. There are few events reported in the literature, so very few teenagers go on to transplant or portal hypertension, variceal bleeding. Those types of things, fortunately, don't typically happen in adolescents, but that gives even less knowledge then about when that would happen if it does. Children with the liver biopsies who we're studying in some of these studies, they might not be representative of the real world because they are the more severe cohort. And so fortunately, there are some new cohorts being built, being developed that are more representative, and that will be important information. And then finally, the type 2 diabetes is the most rapid clinical outcome for pediatric NASH, but it's not probably the focus of a lot of people taking care of liver disease because, typically that was in the, in the endocrine field. So does NASH and fibrosis progress in childhood? And the answer to that is yes. And this is just a nice case example that was published and showing a child at age 11 who went from stage 1C fibrosis to age 16, stage 3 fibrosis. And I think this study that I'm showing you on the right-hand side is extremely important. This is a paper that was published by Naeem Al-Khoury and his group in 2017, and they looked at in the UNOS database for people who had been transplanted from the age of 18 to 40 for NASH, and they found 330 patients who had been transplanted for NASH who fit that definition. And they looked at their outcomes over 4 years. And unfortunately, it was quite grim. So 100 of those 330 had died by 4 years. That's 30%. 230 lived, and 11% of those were retransplanted. So 41% had either mortality or morbidity. So clearly, waiting or not handling this problem for this 16-year-old, waiting simply until they get transplanted, of course, that's not the answer. But I think this information is even more grim, that we absolutely have to avoid having these teenagers go on into adulthood without having some therapeutic or effective treatment that reverses or cures their disease. The lack of ability to cure it. So I'm going to move now to talk a little bit about screening and then diagnosis and treatment. And I just wanted to mention that there are several good guidelines, and I'm going to refer to both of these. So there was a consensus statement published from the ESPGHAN, or the European Pediatric Hepatology Committee, and then also, that was in 2012, and then also more recently, we published a clinical practice guideline supported by NAFLD and also supported by the American Academy of Pediatrics, endorsed this guideline. And notably, this guideline on the left, this was a group of experts, not just hepatologists, but we also had a cardiologist, an endocrinologist, and obesity expert, childhood obesity expert, Dr. Sarah Barlow, participated in this statement. So it had a very good representation from the specialties that take care of the children with fatty liver. So screening. So the current recommendations are that all obese children aged greater than 10 should be screened for fatty liver using an ALT and AST in clinic. And so it's recommended that this is repeated every other year. There may be some children that have risk factors who should be screened more often or earlier, and this was mentioned in the Pediatric NAFLD guideline. So the list here is from that guideline. It's including those with type 2 diabetes, children from Hispanic backgrounds, they have a family history of fatty liver disease, pituitary disorders like a growth hormone deficiency significantly increase risk, and so earlier screening or more frequent screening may be indicated. And then right-sided abdominal pain is kind of a soft symptom. There's an association with NAFLD and right-sided abdominal pain, although it may not be causative, and it may be just because so many children have complaint of abdominal pain and so many children have NAFLD that when it's looked at in studies, there's an overlap there. On the right-hand side, I'm just showing you how children are assessed for obesity. And here is, this is a BMI index for age percentile, and here's the curve. So if they're greater than the 95th percentile, that's obesity. And then greater than the 85th is defined as overweight to obese. And you can see here, this is kind of a typical path, so that there's a significant increase in BMI over the pubertal years right here. So what is a normal ALT? So we get the ALT, it comes back. This is an interesting study by Dr. Schwimmer, and they looked at the cutoff levels for a normal ALT at 43 different children's hospitals and found that the mean was 53, which is pretty high, so 30 to 50. And then they looked in the NHANES data, or the nationally representative data, at normal healthy weight children and looked at the 95th percentile. And it was the upper limit based on the 95th percentile in healthy children is 26 for boys and 23 for girls. So this has become the new standard. And I think the reason why the children's hospitals had these very high ranges up to 53, it developed out of the common practice of individual labs. When they set up their assays, they look at the two standard deviations from the mean of their lab and set that as the normal range. But unfortunately, the prevalence of NAFLD is so high that it's skewing that normal range up. They have too many abnormal, not healthy children in those cohorts. So the better guidance at this point is to use 26 for boys and 23 for girls. This study I'm showing you below is a screening study that was recently reported, and interestingly, they used 2 times the upper limit of normal, so ALT greater than 50, to decide whether a child needed further evaluation or was suspected to have NAFLD. And so using that, they actually had a fairly low number. So they in this obesity clinic in Cincinnati, they evaluated 847 patients over time for elevated liver enzyme and found 47 that had an ALT greater than 50. I think they would have had higher numbers if they had used the 26 for boys and 23 for girls. But again, it's difficult to know clinically how much we should pursue an ALT of 35. When I see an ALT of 35 in a overweight child, I know that means that's abnormal. They have some sort of liver disease, but they don't immediately need a big workup. And for that question, I'm not going to go through that whole algorithm of how to handle that today, but I would refer you back to the NASPGHAN guidelines that we mentioned earlier, published in the Journal of Pediatric Gastroenterology, Pathology, and Nutrition, because they have in that guideline, there's a very nice algorithm on how to handle these low but abnormal liver enzymes. So what is the typical clinical presentation of children with fatty liver? Well, often they do have acanthosis nigricans, although it may or may not be present in every child. They can have mild hepatomegaly, although this is not always palpable, depending on the amount of hepatomegaly and then also the size of the child. they often have abdominal obesity. It may just be a small amount of increased abdominal adiposity, or they can have generalized obesity. They typically will have elevated liver enzymes, ALT greater than AST, and then a hypertriglyceridemia, and frequently a low HDL. Many times before the child ends up at a subspecialty office like mine, they may undergo a clinical ultrasound, and that will frequently be echogenic. Although a clinical, kind of a typical clinically available ultrasound will miss any children with low but abnormal fat levels, because the clinically available ultrasounds don't detect fat under about 33%, and normal, of course, is less than 5%. So the typical pathway to diagnose NAFLD is to first clinically exclude medications. Alcohol, frankly, is not really an issue in childhood, thank goodness. I mean, of course, we know that there are some adolescents who do binge drink, unfortunately, but the progression to alcoholic liver disease is a longer process. So in childhood, we don't see alcoholic hepatitis that they may see more frequently in the adult clinics. We do a serologic exclusion of other chronic liver diseases because NAFLD still remains a diagnosis of exclusion. So we don't have a test to say it's NAFLD, so we have to eliminate the question of these other liver diseases. And then we confirm the presence of fat in the liver. As I mentioned, the clinical ultrasound, it's very useful for ruling out masses or identifying masses, for looking for gallstones. You can, doing a Doppler of the vessels is very helpful for those questions, but it's not accurate for fat. And so in the NASPGHAN NAFLD guideline, the conclusion of the expert committee was to not use it to attempt to diagnose NAFLD. And that's really, that's how our practice has changed here. So in the years past, we kind of used it because it was the only thing we had. Now we don't rely on it. MRI and MR spectroscopy has become more available in many clinical centers. And this technology has been rapidly improving. It was formerly just available in research centers, but that's been changing. There are still some issues with MRI. One, it's expensive, which I forgot to put on this list. And then two, you have to be able to hold still, which is only true for some children, particularly younger ones under 8 years. But it is highly precise, and the measurements for fat are pretty rapid, so that it doesn't need to be an hour-long MRI to get a quick fat measurement. The cutoff on an MR PDFF or MRS PDFF, the proton density fat fractions measured by both of those, the cutoff of what exactly is abnormal versus normal, so is 6% or is 4% or 3%, that really hasn't been set for all the various methods, so there's still information that needs to be determined. This is just an example from some years ago in our center of what an MRI result looked like that our radiologists would receive. So you can see here the lipid percent was 8% on this particular person. MRI steatosis measurement has been validated in children by several different methods. So on the left is MRI PDFF. And here is the histologic grade. So this was MRIs done near in time to a liver biopsy. So by liver biopsy, grade 1, 2, and 3. And then on the side is the MRI PDFF liver fat percent. So here's 0, 10, 20, 30. So you can see that grade 1 is about 10%, grade 2 about 20%, and then grade 3 was somewhere around 25, 26. And while there was some overlap, that's probably generated more by the lack of precision in assessing histologic steatosis by pathology rather than a lack of precision by the MRI PDFF. On the right-hand side, this is another method of volumetric liver fat fraction, and again, showing very good demonstration of that the grades of steatosis can correlate with percentages of fat by the VLFF. So another method to measure fat is controlled attenuation parameter, and this is abbreviated CAP, and this is a novel ultrasound-based method. And this is a study on the right that I'm showing you that compared CAP measurements to liver biopsy determined steatosis. And it was able to differentiate steatosis versus no steatosis, as shown in the top figure here. But again, similar to some of the other difficulties with ultrasounds, it was not able to differentiate the mild to moderate versus none. You can see there's some overlap here, and then mild to moderate versus marked. But I will say that this is the only study that I found on liver biopsy and CAP, and it's a small study, so the number of children with steatosis was relatively small, and so I think that larger studies need to be done using CAP, and then potentially measuring CAP versus MRI fat measurement, given that increased precision of MRI might be very helpful. So the conclusion was that CAP was useful and able to differentiate steatosis, but not so useful for differentiating specific amounts. So once we know that fat is present in the liver, as I mentioned before, the differential diagnosis still remains wide. So you can't just say, oh, there's fat in the liver, this is non-alcoholic fatty liver disease. And this is a table from the NASPGHAN guideline, and it's showing here many of the conditions that can also result in hepatic steatosis. So this is helpful when going through the diagnostic process for an individual patient. So in the next step of the process of diagnosing, the next, often once a child is identified with NAFLD, the next question is severity. And non-invasive fibrosis scores are frequently used in the adult clinics in order to differentiate who needs a biopsy and who doesn't. So in other words, who's got fibrosis, who's at risk of progression, and who's not. Unfortunately, the tests that have been developed to date perform very poorly in pediatric cohorts. And here's a group of figures showing the AUC curves for ALT, and these are all predictors of high increased fibrosis versus low fibrosis. And so we did this validation study showing the ALT, AST, the AAR, APRI, FIB4, and then this is a pediatric NAFLD fibrosis index. And you can see the AUC curves are really quite dismal. So unfortunately, these scores are not going to be helpful clinically to differentiate. Fibrosis assessment can also be done by transient elastography. So here's a figure on the left showing the shaker, which propagates the shear waves, and then it's measured by ultrasound. So this is a study on the right looking at children who had liver biopsies at the same time as transient elastography. And you can see that there is a very nice trend of increased liver stiffness across the scores of fibrosis. So the fibrosis goes from none to 1, just some portal fibrosis all the way to cirrhosis. And then here's fibrosis area fraction, again, a nice correlation. And then here is looking at the patients by their fibrosis score and doing the box and whisker plots. And this is a little bit more informative than the correlations, because you can see here that they're typical of some of the other non-invasive tests. There's very good differentiation of the low fibrosis compared to high fibrosis. So there's really no overlap. But it's when we get to the middle grades of fibrosis that it's difficult to know. So if you have a patient who's in this area of liver stiffness, we don't know if they have this lower, the F3, or if they have F5, because there's some overlap there. So hopefully the precision of this will continue to increase. And I think, again, more data would be helpful with direct comparisons to fibrosis. Fibrosis, just like steatosis on liver biopsy, is not very precisely measured by a pathologist. And so the difference between an F2, F3, F4, this is all fairly subjective. And so that also affects the ability to validate novel measurements. So just to conclude, so this is from a review that was published in Children last year, and they concluded that regarding the ultrasound-based methods for fibrosis, that their benefits are that they're more available, they're less expensive, but the accuracy is decreased at these lower fibrosis stages. Fibrosis can be assessed by MRI as well. Again, a little bit more expensive, not available for all children because of the need for sedation. And then again, significant overlap between the fibrosis stages. So here they did the 0, 1 to 4, and you can see, so here's these are 2 different reading centers and then an automatic reading to try to take some of the subjectivity out of the reading of these MR elastographies. But you can see, look at the overlap between stage 1, 2, and 3. It's really only 4 that was significantly different. And then the volume and the cohort with stage 4 was pretty low. So I think that these, it's very exciting that we have novel non-invasive measurements in development, but we need more work before this can be used in the clinic. So when would we consider a liver biopsy? What's the utility? Well, it confirms the diagnosis. So in cases where the liver enzymes are very high and especially if the child has other red flags, a liver biopsy is very helpful to confirm the diagnosis. It also establishes severity. So if they've had disease more than 2 years, if they have a high ALT, if they've failed to respond to lifestyle changes, then we are more concerned that they may have fibrosis. And so one of the options would be to do a liver biopsy to evaluate that. And then some people use vitamin E to treat children with more severe disease, such as NASH and fibrosis. And it's important, if you're going to use vitamin E, to know the histology so that treatment response can be assessed. And so a liver biopsy would be useful in that case. All right, so we've screened, we've diagnosed. So now what are the treatment considerations in children? So first of all, if we're going to treat, we need to know what the definition of a response is. And right now, basically, we use a decrease in ALT, frankly. This is what we've used classically in almost all liver diseases, and I think as hepatologists, we kind of understand what a decrease in ALT means intuitively. On the left-hand side here is a figure from a paper that will be coming out in children, and this figure shows that over, this is data over 2 years for NASH and for fibrosis on the bottom, and it's showing children who improved versus stable versus progressed. And you can see that if they improved their NASH and if they improved their fibrosis, that their ALTs dropped more than the other 2 groups. Other things that can be used are a decrease in steatosis, a decrease in fibrosis, non-invasive markers, resolution of NASH, and resolution or decrease of fibrosis on histology. Some of those clearly are not are research-based, but resolution of NASH, decreased fibrosis on histology, those could be used clinically, particularly if after at least 2 or 3 years. So we don't recommend a biopsy, repeating a biopsy in the short term. So the strongest recommendation for treatment in the guidelines was to reduce sugar-sweetened beverages. And part of this is because sugar consumption is just frankly high in children. So this is nationally representative data on the consumption of sugar in children, going from age 19 at the top here all the way down to age 1. And here on the left, you see if they're children in the US at age 1, the blue is added sugars, and then the red is free sugars that come from like juice and things like that. Children at age 1 are already having double the recommended. The blue line here is the recommendation of how much, 25 grams per day, how much a child should consume. So I think this is really shocking. So by 1 and 2, they're already getting more than double the amount. And of course, by the teen years, it's just pretty much atrocious. So that should be the first focus. And I'll show you a little bit of the pathophysiology just to help understand why sugar is so important. So this is a figure showing, this is from a seminal study done by Dr. Park's group. This shows that de novo lipogenesis here, this gray bar, is dramatically increased in folks with high liver fat compared to low liver fat. This was a tracer study, and they looked at fat sources, so free fatty acids, dinner, unlabeled, and then here's the de novo lipogenesis. And this difference explains why patients with NAFLD are much more susceptible to sugar consumption compared to those who aren't, because fructose fructose feeds de novo lipogenesis. On the right-hand side, Dr. Klein's group showed that weight gain even drove up de novo lipogenesis even more. So here's fructose. So this is in the sugars that we just consumed. Glucose is as well, but fructose is uniquely lipogenic because fructose skips this enzyme, the phosphofructokinase, which is the rate-limiting enzyme for glucose. So rather than the glucose going continuously down to the lipogenic pathway, making triglycerides, which are then loaded onto VLDL, glucose can be rate-limited and then shunted out as glucose into the periphery, where excess glucose is probably still metabolically a problem, but it's not as lipogenic as fructose. We did a study demonstrating how lipogenic fructose was by giving fructose drinks and 2 children with NAFLD, sorry, on the bottom, and without NAFLD on the top. And you can see that the plasma triglycerides over the day from 8 a.m. to 7 a.m. the next day, that the plasma triglycerides in the children without NAFLD didn't really go up that much with the fructose drinks at breakfast, lunch, and dinner. Sorry, these arrows got moved over, but imagine them over here. So breakfast, lunch, and dinner, they got their fructose drinks. And look at the triglyceride elevation here. I mean, going up to way above 300. So clearly, for the children with NAFLD who already have upregulated de novo lipogenesis, you give them fructose, which drives de novo lipogenesis, they get much higher levels. And so, therefore, sugar reduction has become a critical component of treatment of fatty liver disease. This is another study that they fed the patients glucose drinks or fructose drinks and showed that visceral fat, total fat, subcutaneous fat all went up, but visceral fat was the most different from glucose. On the right-hand side, again, sugar colas drove up liver fat. So I feel like I'm probably repeating this message over and over, but again, it emphasizes the importance that sugar needs to be reduced. Here's what happens if you do reduce sugar consumption in children. So this was a 9-day study with children who were overweight. They didn't necessarily have fatty liver, and they used fructose restriction. So they fed them a low fructose diet. And you can see here, I'll just focus on this figure right here, that in the liver, the fat greatly reduced, almost 30% reduction when they did that 9-day restriction in fructose. And here's de novo lipogenesis, so much better at day 10 after the reduction compared to day 0. So what else besides reducing sugar? Physical activity is strongly recommended. This is from the guidelines. And then just a comment on physical activity. It's better to do things that are integrated. This was a pediatric 10-year outcome study, and exercise that was integrated into their lifestyle was much more effective over those 10 years. So I like this quote here: people rarely succeed unless they have fun in what they are doing, and that applies to kids particularly. So no treadmills, please. Better to go to the playground, go to soccer, or something fun. All right, how often do we have to see them in clinic and follow up the NAFLD? Can we just diagnose them and set them free? Unfortunately, no. And so this has really resulted in a big volume, kind of overwhelming our liver clinics, but it's important that they come back frequently so that they can get the counseling, the support, monitor the ALTs. And then also we're screening for diabetes, screening for hypertension, dyslipidemia. So outpatient visit frequency is important. Just real quick, bariatric surgery, there is some data. So the bariatric surgery, this is a cohort showing that bariatric surgery can improve the NAFLD score. So here's pre-surgery, 1 year post-surgery, and 2 years post-surgery. So lastly, the mechanistic targets for pediatric NAFLD are pretty similar to adults. I'm just kind of showing you a whole list here of targets that are potentials. We have a number in phase 2 trials, so that's exciting. Some years ago, this trial was published, and it was comparing metformin, vitamin E versus placebo. And I'll just call your attention here. So the trial was negative. The 3 groups were identical at end. So here's the ALT on metformin, vitamin E, and placebo. You can see there's no difference. But on the right-hand side, here's metformin, and you can see they did drop more weight compared to the others. But then there was this is the regain after they came off metformin. But if you look here, this is at the end of drug at 96 weeks. And so metformin is used off-label by some pediatricians to treat increased weight. And I think this is something that needs more study, because even in this trial that was negative for the liver effects, it was fairly different in the body mass index. Vitamin E, just to summarize, there's insufficient data for conclusive recommendations. That was from the guidelines. So some people use it based on the evidence that it did improve some of the histologic features in the TONIC trial that I just showed you. But it's important to remember that if you're going to treat inflammation with vitamin E, that they will need a liver biopsy before doing that, and that it will need to be followed up. Cysteamine is a potent antioxidant that was tested in a randomized controlled trial a couple of years ago. Unfortunately, it was negative. There was some interesting differences from the older to the younger children. So potentially, something potent, some other type of antioxidant could work, but I think we might have to phenotype the children better. But again, not ready for prime time or for clinic. And just the last future one I'd like to mention is losartan. We just published a pilot study of losartan, and this is the data. And it was a crossover study, and it got a little messy because actually we had a strong carryover effect despite a 6-week washout. So the children who were on losartan during the first period still had improved insulin resistance and ALT when they went into the placebo period, which of course was all blinded in the second period. So statistically, we couldn't do group analyses, but I'm showing you here figures of the raw data, and you can see that on losartan, there was a nice trend down in ALT in many of the patients, and again, HOMA-IR, insulin resistance, nice trend down. So on clinicaltrials.gov, you can see that there's a new pediatric losartan study starting by the NASH CRN. So it's exciting that a larger, better designed study will be able to look at that. So summary for treatment, as I said, sugar-sweetened beverages is the first and foremost. If they get that conquered, then it's other sugars and a healthy, well-balanced diet, exercise. There's no medications that are indicated right now. Bariatric surgery can be considered in select individuals who are very obese and have other comorbidities. So just to conclude, NAFLD in children is highly prevalent across the world, and the diagnosis at present is cumbersome, but progress is being made in the non-invasive diagnostics field, and I'm very excited about that. Treatment for now focuses on lifestyle changes, nutrition, and physical activity, but the future is bright for therapeutics, and again, I'm looking forward to having a medication that I can use for my patients. So thank you for your attention, and I'm happy to take questions.
Thank you, Dr. Voss. That was very information rich. I'd like to remind everyone we are monitoring your questions in the background. So if you'd like to submit a question for Dr. Voss, please type it into the questions pane. I would like to now introduce Jeff Wong, Echosens clinical specialist. Jeff is going to be reading the questions to Dr. Voss. Jeff, please read the first question.
Thanks, Jerry, and thanks, Dr. Voss. The first question that I have from a large pool of questions that were submitted from different channels is what are your criteria for ordering a FibroScan test?
Oh, so that's a great question. So we are just in the process of getting FibroScan set up to be clinically available in our clinic. And so, frankly, we don't have established protocols. There's not a validated indication for FibroScan in children yet. And so, yeah, so I apologize for not being able to just give you our protocol, but we don't have a set protocol. I think it varies right now, provider to provider in our clinic. So some use it very frequently on almost every patient, and then some are being more select.
Thank you. Jeff, next question, please.
Sure. The next question is, what are non-diabetic factors for fatty liver disease?
So, sorry, I'm just trying to think about what that question is asking. So, non-diabetic factors for causing fatty liver disease?
Yes, the question was, your presentation was very diabetic centric. What other risk factors do you consider?
Oh, sure. So, the risk factors are family history of fatty liver disease, gestational diabetes in the mother, the presence of Hispanic heritage. Asians are also at a higher risk compared to Caucasians. African Americans have the lowest risk. Obesity is obviously a risk factor. So that's probably all we know at this point, again, because of the lack of longitudinal data in childhood. The diabetes focus of my presentation, I think, is driven by the fact that that's the most, it's the complication that's going to occur the soonest for a child that is diagnosed with fatty liver or has fatty liver undiagnosed. And so while fatty liver is asymptomatic and can cause, future problems, and we think of those future problems being in adulthood, unfortunately, the diabetes has been changing the path, and so they're getting that sooner and in childhood, which is really amazing. The prevalence of diabetes in the general population of children is about 2 cases per 100,000, and then so if you take a NAFLD cohort, it's 4 per 100 or something, just an incredible increase.
Thank you. Jeff, next question.
All right, so the next question is, how do you discriminate pediatric patients with progressive fatty liver disease who require disease management from patients with simple steatosis?
That's a very good question again. So what we do right now is we treat them very similarly, except for the frequency of visits. So if a child has simple steatosis, we do lifestyle counseling. We have several visits with a nutritionist. Once they have established that they are doing well, they've overcome barriers, their BMI is stabilized, we can return them to the care of their pediatrician, who would then follow their liver numbers over time. When a child has steatosis, inflammation, fibrosis, has the more severe version, or is not responding to the lifestyle counseling, we tend to follow them up in our hepatology clinic. Other centers may have different models, but that I'm telling you what we're currently doing.
Jeff, next question, please.
Next question is, what threshold values do you use for moderate fibrosis and advanced fibrosis with VCTE or FibroScan?
So, there's no validated numbers for children with NAFLD for FibroScan for the cutoff. So, so I'm sorry, we don't have that.
And Jeff, I'll read the next question while you're organizing the one after. This one just came in, Dr. Voss. What are your thoughts on omega-3 in pediatric NAFLD?
Oh, that's another good question. So no large randomized controlled trial, which is basically the same with everything. Fish oil is used in children with hypertriglyceridemia, and so I would probably look to the cardiovascular literature for, for guidance on who to use it on. Hypertriglyceridemia and fatty liver disease, almost always coexist. So that can be a helpful guidance. It'd be an interesting one, again, to test in a larger study in children. I think it has good potential, but no data right now, so we can't use it in clinical practice.
Very good. Jeff, next question, please.
Next question is CAP useful in pediatric patients tested with the M probe? If so, why?
So the M probe and the XL probe both can do CAP, and the S, or the probe that we use in the smaller patients, it does not have CAP. So absolutely, we can use CAP when we have a patient large enough for the M probe, which is actually most of the NAFLD patients, frankly. What the CAP data means at this point, I don't think we know because of the lack of data. So I showed you a study that had CAP and liver biopsy, and I think it was only 23 patients in that study that had steatosis. Many of the patients had other liver diseases that didn't have steatosis. So I would love to see a study where CAP was done using the M probe or the XL probe, and in children with the thoracic circumference of 75 centimeters or greater for the M probe, and that they had an MRI at the same time, because MRIs are hard to get, so having something like CAP would be very helpful, but we need the data.
Very good. I'll read the next question, which just came in while you prepare the next one, Jeff. So Dr. Voss, what is the data on normal weight pediatric patients with metabolic syndrome, insulin resistance, and NAFLD? There's some suggestion that sugar-sweetened beverages are an independent risk factor regardless of BMI.
I agree, and I only have anecdotal data, but we absolutely see very high sugar consumption and in a normal weight patient who have, and they are diagnosed with NASH and fibrosis. And we have, I don't think there's a study looking at the percent of children that have lean NASH, but it absolutely happens. Like, I see this in my clinic. So I think this is an area that will become more important over time as we have more, actually, frankly, as we have more non-invasive methods to measure liver disease, then we'll be able to do these better studies. We can do a study where we can look at a group of people who all self-report high consumption of sugar drinks, and then see what the percentage of them, regardless of BMI, what percentage have fatty liver disease. So very interesting area.
Very good. And we have time for one final question. Jeff, could you please read it to Dr. Voss?
All right. So last question that we have here on this list is, what we know that there aren't too many studies out yet, but what is the best CAP threshold that you have and that you use to discriminate marked steatosis from lesser degrees of steatosis? There's a publication by Dr. Desai et al. Suggesting that 313 decibels per meter is a potential threshold.
I'm just going to go back. I think I have that Desai figure, right? Let me.
Yes, I believe you had that slide.
Yeah, so look, we can just show that. So can look, I mean, I think you can, kind of make your own assessment here. There's substantial overlap between steatosis and no steatosis. So in my clinical practice, without a better, larger, validated study and less overlap between the steatosis category and the no steatosis category, this cannot be used to diagnose a patient. This is insufficient accuracy in data. So in order to determine a disease in a patient, it's important that we follow the guidelines and follow the evidence that we have available in the literature. And today, that is that steatosis measurement is accurate by liver biopsy, and there are several validation studies in MRI with high enough support, high enough accuracy to be clinically indicated. Although, frankly, the guidelines came out before the MRI was validated. So if following the guidelines, I think right now the best is liver biopsy. So
Very
we're
good.
a little stuck right now, so I'm looking forward to the future.
All right, that concludes our time. I'm going to hand it back to Nikki to make closing comments.
Thank you, Jerry. This concludes today's webinar. On behalf of CLDS, I'd like to thank Dr. Voss for her talk on this very important health topic, and of course, you, our listeners, for your attendance. A copy of the webinar will be available on the CLDS and the ecosins.us websites. Thank you and enjoy the rest of your day.